All right, well, welcome everyone. It looks like most of the people are signed on, and we're going to get ready and get started again today. Welcome back, everyone who's attended our last four series. This is the fifth in a six-part series. Today we're going to be talking about device delivery and titration. It's sponsored by Keller Labs and us at Dental Sleep Solutions. Speaking of Keller Labs and Dental Sleep Solutions, Rich, how'd the course go last weekend? We had a course in San Antonio, and they went pretty well from what I understand.
Yeah, it was fantastic. We had about 20 dentists there, and San Antonio is a great place to do that. And the good news is Keller has agreed to do some more of these courses with us next year. So we won't have those dates yet, but we ask you to check back into Keller's website, and you will see some more information about that. We've committed to doing several of those with them next year, and we're going to do the same type of format where we have a first day that's about half in dental sleep medicine, and the second half is in how to implement this in your practice. And then we're going to limit the second day to just 5 dentists, and then we're going to do some real hands-on stuff where we go over home sleep testing and how to actually do a lot of this stuff and deliver taps and EMAs on each other and things like that. So thanks for asking. But yeah, it went great, and you see the information about Keller there, and the next slide you see some information about Dental Sleep Solutions, and we hope that you guys will visit both of our websites to find out some more information about us. And
it's been a good 6 months here working with Keller Labs. Have been very beneficial, and the people who have gotten involved and started this and called us for advice, called Keller. Keller's a great resource. Kind of what we're about is we're really the only turnkey solution from start to finish. If you want to get involved in this and want to take the guesswork out of it, Rich and I have figured it out for you. If you want to know more about that, contact us at Dental Sleep Solutions. But we can really take you from a novice to doing this as a big part of your practice. We're passionate about it, and we can give you all the details if you want to contact us. Most of you have attended our other 4 parts of the webinar, and so we don't have to go into detail about us, but just suffice it to say that Rich and I have been doing this a long time. This is what we do for a living. Both of us limit our practices to sleep now, and if you have questions after this, we'll try to get to them. If we can't get to them during this webinar, feel free to contact Dental Sleep Solutions, and we can get your questions answered.
And we have one more in our series. The last one will be November 9th, and that we'll talk about marketing and medical insurance billing. So kind of save the best for last there. But today, we've got an awful lot to go over. So first of all, a little housekeeping type of stuff for your CE. Remember that in order to do that, you have to do a couple of things.
If you want to get your CE, you're going to get an email with everyone who attends the webinar from Dental Sleep Solutions. It's going to be sent to the email address that you registered for these webinars. You must completely correct a 10-question quiz within 7 days after receiving the email. You're going to click on the email, enter the required information, and then complete the quiz. You're going to need your AGD number. If you don't have an AGD number, then just put NA for that, and you'll get your CE credit.
Today, let's jump in and get going, because we've got an awful lot to cover today. We talk about delivering the device and titrating it. We're also going to talk about some side effects and throw you some pearls that we found after Guy and I together have done thousands of these taps and EMA. So we have some good advice for you on how to handle some of the problems that are going to come up, and they certainly will. You need to know that. You need to make sure that your patients know that there are protocols for advancing these devices and how quickly we do that. And there's kind of a left sideline and a right sideline, and we're going to kind of give you the middle of the road. And you can steer a little bit from that, but we're going to give you a real good idea about that. And when do you test them, and how do you test them? So we'll talk a little bit about some home sleep testing devices and, of course, defining success. What is success? So that's kind of an overview. And Guy's the one writing the test, so especially listen to him when he talks.
Well, we've come a long way in the last 4 series. So basically, by the time we've gotten here, the patient's been evaluated, diagnosed, examined, measured, weighed, impressed, groped, and quite possibly even probed. Now what are we going to do? So, we're at the point where we're going to get started with the treatment and taking the impressions, and now the patient's going to start wearing their appliance. So at the delivery, how does that work? Well, the thing I really like about the tap and the EMA is that you can separate the two and try them in. Not all appliances you can do that with, and I really think it makes the delivery process somewhat easier. Try the upper and the lower independently and just make sure they fit. They need to fit tightly enough to hold the jaw together, because both of these devices hold the jaw somewhat together. The tap a little more than the EMA, but they both keep the mandible closed, which is, I think, makes it for a more effective appliance. So it has to fit tight enough that they won't, what I call, pop out of the appliance, but not so snug they're going to pull out crowns and so forth that are in their mouth. Sometimes Rich and I found it valuable to relieve the facial, the maxillary, and the lingual, the mandibular teeth. In particular, if there's a tooth that's lingual version on the mandible or facial on the maxilla, it's going to catch that tooth and put a little extra pressure on it, because that's the directions of the forces. So or if you have a tooth that's periodontally involved, or you're a little bit worried about a shaky crown or something in particular, that's really important. Then once you feel that they fit well, then put them together and then check for the bite and the interferences, making sure that they hit evenly, depending on whether you have it open in the anterior like an EMA with the stops in the back, or the tap. Sometimes you want the if you have the tripod effect of the tap, or sometimes you just want to hit it in the front. Whatever your goal there is, make sure they're hitting correctly. You may need some articulating paper on occasion to check that.
Very good. And we'll go into a little bit more detail about that in the next couple of slides. And, here's a picture of the TAP 3 on the left, and a little lesser known TAP 3s on the right there. I thought Dr. Thornton would appreciate that. So, of course, we have the TAP 3 Elite also, and Keller's one of the few labs that can actually do this right now. Labs have to go through a certification process in order to do this. And it's a little bit different. I like the bar on the bottom. They've gone back to that. I used to take the old TAP 2s and the little socket that they made and just throw it away and put a bar in like that. So it gives them a little more side-to-side movement. And the upper hook is now replaceable. So you can add vertical and add anterior, posterior as well, just by changing that. But let's get into the delivery of the TAP, actually. Remember that the TAP, you can get in the inside part of it, you can get in two different materials. It's available in the DuraSoft, which is that little soft part that goes on the inside of the hard acrylic, or you can get thermacryl. So I'm going to talk more about the thermacryl right now, because that's a little more difficult to fit and do. The thermacryl is an amazing material. You heat that stuff up and it goes from an opaque white to kind of a clear, and it's kind of like Play-Doh at that point. It kind of has that consistency. So what you'll do is to put both of them, upper and lower, in real hot water, and we just have a little teapot type thing that heats water in the operatory there in a little porcelain bowl, and we heat the water up and pour it in and drop the upper and lower in there. And as soon as that stuff starts to get clear, I usually do the lower first, and I'll center the lower, push down on it a little bit, and then I'll have them bite down on it. And I'll just bite down on it all the way. And while they're biting on it, I kind of stick my finger in there and clear off all of the facial area, because I'm usually going to trim that off anyway. Let it sit in there for about 10 minutes and then tease it out. Push it back in, tease it out, push it back in. So relieving some of those undercuts as you do that. Then take it out, put it in a bowl of just tap water, out of the sink, and that will cool it. So while that one's cooling, I put the upper one in. Now, because that hook's on there, you can't have them bite into the upper one, but you want to push that thing in as hard as you can. So I kind of get around their head and I pull up as hard as I can while they're pulling their chin down. So it doesn't matter if you do the top first, the bottom first, doesn't make any difference. So you're just trying to get that thing seated all of the way. If you don't get it seated all of the way, then your vertical will be much, much higher than it might need to be. And remember that controlling that vertical a little bit can help open the airway. But as a general rule, I like to start with it being closed more, because by the time you add that hardware and that plastic in between there with the tap and that anterior hitting like that, you're already going to be open at least 4 millimeters. So you just want it to seat all the way for as much as you can. And once those things cool, you kind of take a Bard Parker scalpel and you trim off the excess. Like Guy said, the lingual of the lowers, any tooth on the lower that's kind of in a lingual version, and the facial, anterior implants, anything that you're a little bit concerned about, just trim a little bit more around those teeth, and then have them try them back in. Just make sure they're wet when they put them in. If it's a little bit too tight, you can take it out, heat it up for 10 seconds, put it back in, tease it in and out more if you want it looser. If you want it tighter, you put it in, push on it a little harder, and leave it in for a little bit longer. So it takes a little bit more time to work with the thermocryl, but it's an amazing material, and the thing I like about it is you can always make it tighter or looser. The Durasoft, in contrast, once you put that thing in, you can always make it looser, but you can't hardly make it tighter. There are a couple little tricks, but in general, that gives you a real good idea about how to deal with the tap that has a thermocryl lining in it.
Yeah, I think that you do more of that than I do. I probably tend to do the Durasoft material a little bit more. The advantage to the thermocryl, like you said, it can always be tightened, and if people have a crown done down the road or in the middle of some sort of treatment that's a perfect material, it's always going to fit because you can always refit it. It does require a little more maintenance, don't you think, Rich, down the road? It's going to wear out a little quicker, and you're going to have to the patient's going to come in, but that's not always necessarily a negative, because we want our patients to come in annually for recall examinations to see how they're doing, and if it starts fitting looser or something, then that may be what will bring them in the door.
Yeah, that's a good point. They do tend to discolor a little bit over time. The thermocryl does. It becomes a little bit brittle, and then it will start to chip out. So most of the time I've had them last about 2 years, 2.5 years. At that point, a patient comes in, we send it to the lab, they grind out the lining, and they put a new lining in there, and we refit it, and usually we can get another year or two out of a tap. So remember also that if you do the first tap in Durasoft and it gets too loose and it starts to wear out, that you can have them grind that out and put thermocryl in that, and you can get another year or two out of that.
Right.
And you also brought up a good point about somebody who's in a transitional type thing. Remember, sleep apnea is a serious thing, and we want to treat it. And somebody says, well, I really want to get these crowns done and that stuff too. Well, great. Well, we'll make you a tap. We'll use thermocryl, and we'll transition you through this period as well. That's a good point.
All right, great, Rich. I'll talk about the EMA and the delivery of it for a moment. Most of the time, the EMA is made in a harder acrylic, which Keller does a great job of making sure they fit. Just make sure you take accurate impressions like we talked about in the previous webinars. Polyvinyl of some sort is usually recommended. Get them back. Again, you can try these in two separate pieces. So trying the upper and then the lower individually, making sure they fit, make sure it doesn't put any pressure on a tooth. If a tooth out of alignment, sometimes it'll cause a little discomfort. So ask the patient if after they have it in their mouth for a moment, is it causing any pressure on the teeth? And it shouldn't be touching the tissue anywhere, but if by chance it is, relieve it appropriately. Then once they're both in place, have the patient bite down, make sure they're hitting even. Most of the time these are made, you can get them made without the posterior stops, but I prefer them in most cases that they make the stops in the posterior, which leaves it open in the anterior for more tongue space. So make sure those stops are hitting evenly. And then once that's taken care of, then you can measure from button to button as they protrude. And our goal is to get the jaw as forward as we can without causing discomfort. Usually that equates to 40 to 60% of the maximum protrusion. But the neat thing about this EMA is you just have them put it in without the bands on, move forward, and then you can kind of measure between those buttons and see what the appropriate band is to put on. Bands come in different lengths, but they also come in different rigidities. In general, we take our bite at 40% of the maximum protrusion, does up to 60. But at this point, even though we took a protrusive bite, we can go ahead and advance them a little bit more if it feels comfortable to the patient. Put the bands on. One key on those two, patients always mess this up. There's a little recessed area on the bands that goes towards the buccal so that they can catch over the little hook. Make sure that that's placed properly. I genuinely start with the white bands, which are the most flexible and most comfortable for the patient. They do stretch out quicker, and oftentimes we don't end up with the white bands on there. But starting out with the white bands at whatever length seems to be comfortable for the patient is great. Put it in their mouth for a few moments, maybe 5 minutes or so. Have them make sure that no teeth are hurting, that their jaw feels comfortable, and then that's usually a good starting point. And then wherever you start, make sure you note that for your chart and records for future visits, so we know where we started and then where we're going. Anything you want to add about the EMA delivery, Rich?
No, that's good. The one thing I've noticed, the only time I really have trouble with EMAs is on people who have pretty nasty teeth. And nasty, I mean in the sense that one's going to the right and one's going to the left, and the next one's going forward and the next one's going back. When you look at a mouth and it's got so many undercuts, you think, man, how am I going to get something over all of those teeth and draw it off? I think the few times I've made mistakes with EMAs, is in putting them in patients who have teeth like that. There are just too many undercuts to deal with like that. So, and that comes from doing hundreds, if not 1,000 of the EMA. So one thing you might look at is when you look at the occlusion and how those teeth are in each individual arch, how they draw out and how they do that.
Right.
So as forward as they can be, you mentioned taking a bite. Do you take a bite on the taps and the EMAs? Do you take a bite no matter what?
I do. I think it helps the lab know where to mount things and to start. But either one of these appliances, you could, I guess, take just an MI, maximum intercuspation bite, since they're so adjustable. Do you always take a protrusive bite? What about yourself?
I think it's a good idea. I think it takes a little bit of guesswork out. It just takes a couple of minutes to do in the office. So yeah, I think it's a great idea to do that.
You could get by without it with these particular appliances. Lots of other ones out there you can't. But again, I usually take the bite between 40 to 60% of the protrusion, the maximum protrusion, like we discussed in the previous webinar.
Okay, so you've given them the device now. You've got them where they're in a kind of a forward and comfortable position. When do you see them back, Guy?
Well, you and I think disagree. I don't know if we disagree. We do this differently. I used to be on the schedule here. We see them a week, and then 3 weeks, 6 weeks, 12 weeks. I don't disagree with that. But I kind of happened into a different schedule, being that I have a couple of satellite offices that are one's in Tampa. It's an hour drive each way. And so to maximize our time, we kind of went to a 3-week schedule, because that gives us enough time to get appliances back. If I go and I do 4 or 5 consults, and I do 3 or 4 beginning treatments, I'm delivering 3 or 4 appliances. It makes for a busy day that way. And we kind of got on that schedule. So I don't see them at 1 week anymore. I see them at 3. And I found that to be actually beneficial, because at 1 week, they're still kind of getting used to things. They may have some minor complaints that you'll have to address that they'll just get over by 3 weeks. That's kind of what I found out, because I used to be on the 1 week schedule. The important thing is, if you're going to go to the 3 weeks, and I'm just saying that's the way I do it. I know, Rich, you're going to say you do the 1 week. They have to understand that they have 2 goals when you give them the appliance. The first and foremost goal, above all else, is that they wear it every night, no matter how, if they feel the same, better, or worse. Most of the time they're going to feel the same or better, but the goal is just to wear it. That's what they have to understand. And if they can't wear it for any reason, they need to call us. And then we'll see them. They'll have to come up to our other office, or we'll go to see them or something like that. So I tell them I'm going to be upset at you if I see you in 3 weeks and you haven't worn this every night. I think that's the key if you're going to go on the 3 week. The other goal of treatment is to say, I want to know how you're feeling, how it's working for your subjective findings down the road. So I think other than that, we're pretty much the same. You see them about 3 weeks later, and the goal initially is to see how they're doing subjectively. And that could be anywhere from snoring to sleepiness to waking up with headaches, multiple times waking up at night. Maybe now they're sleeping through the night, because our goal of treatment is twofold. I think one thing we really do a very good job as dentists treating obstructive sleep apnea of dental appliances is that we address symptoms and AHI, or what I call objective findings. Let's work on the symptoms first, because if we get the symptoms taken care of, I think that's half of the goal of treatment. That's why the patients are there. They don't really care about AHI as much as we do. We'll check the AHI later with home sleep testing to make sure that that's going well.
That's a good point. All of those things that you brought up are good. Remember, sleep apnea is a syndrome, and a syndrome is defined as a cluster of symptoms. So let's just not hang a number out there like an AHI. And you all remember that's the apnea hypopnea index. index, or the RDI, the respiratory disturbance index, and say, well, we just have to get that below 10, or we have to get that below 5. Well, you can do that, and a patient's still sleepy and falls asleep, driving home from work, gets in an accident. So you bring up a couple of really good points. I want to drive home there, Guy. Number one, make sure it's comfortable and they can wear it. It really doesn't matter if you see them in 2 days or 2 weeks or 3 weeks. Make sure that they understand they can call you if they're having problems, a tooth hurts, something like that, so that you can adjust it. It's much more important that they wear it and that we begin to do that. So now we fit the appliances. We've kind of got them started in a bite that they feel comfortable with, that you feel comfortable with. You have an idea about where that is now. You're documenting that, where they are, what band they're on. With the taps, we've always used, you turn it counterclockwise, looking at the screw all the way back, and then we count half turns as you go forward. 1, 2, 3, 4, 5. So our parlance that we use in the office is, I'm at 7 turns, or I'm at 9, or something like that. So get some kind of system that you use for how you do that. And do you recall, Guy, what is it, a half turn?
A half turn's
a quarter millimeter.
It's a quarter millimeter, correct?
Right. So it takes 4 half turns to make a millimeter. And the bands now with the EMA, they're coming out with the bands that are in 1 millimeter increments now. They used to be 1.5 millimeters or so. So that's going to be real easy. They're just going to have the numbers on them, like 15, 16, 17, 18. And we know those are millimeters from the center of the button to the center of the next one. So we've started them. Let's, now we're going to start to follow up. How are they doing? How are their symptoms doing? And where do we go from there? Well, now they're going to start having some side effects, right?
Yeah. So basically, what I would like to mention is, so we see them at 3 weeks. What do we ask for? We look at the subjective of findings. If all that's well and good, then we may want to go to objective. But occasionally you will have side effects, and we should talk about those, because I think we want all dentists to get involved in doing this. And, side effects, if they do their first appliance and they have something that causes the patient discomfort, that may prevent them from implementing this in their practices. And most of these side effects we can accommodate. If you spend the time with the patient and understand what's causing a side effect, we can usually address it and make it either go away or tolerable to the patient, because if we don't, then they won't wear the appliance. And the reason we are here talking about this tonight, and the reason you're taking the time out of your schedule, is because of the fact that dental appliances worn for sleep apnea have much higher compliance rates. And if we can address these side effects, we can help that even more. There's a whole list of them here on your screen. The next slide is going to talk about something that I think can help occlusal and bite changes. And it's also something you want to make sure you do at the delivery appointment, is making a morning aligner. So we'll talk.
Go to that next slide. Real quick.
Let's go do it and come back. Yeah, I think that probably the biggest side effect we have, if I had found a little genie in a bottle and I could make one wish towards the treatment of sleep apnea of appliances, it would be that we didn't have bite changes or tooth movement with dental appliances. It's probably the biggest drawback in my opinion. That being said, I think we can overcome a lot of it if we can get the jaw to go back in the morning. My personal belief is that the majority of these notable bite changes are due to the TMJ joint being transposed down and forward and not getting back in the morning. So when we talk about delivery of the appliances, yes, their goal is to wear it. Yes, their goal is to tell us their symptoms, but also they need to do something to get their jaw to go back in the morning. And you can get these from Keller, I do believe, where we get them. And this is a really cool thing that I think Keith Thornton invented. And it's this, what's the materials this stuff made out of? You have any idea, Rich?
Yeah, it is. It has a thermocryl base, which is the same thing that we can put into the taps, and it has Kevlar fibers embedded in it. Yeah, it's pretty cool stuff. So it'll hold your trolling motor on your bass boat. I can tell you that. It's some pretty good stuff.
This stuff gets really hard, but when you heat it up, and you don't even really have to get it all that hot, it turns into almost like paper. And so what you want to do is at the delivery appointment, before their jaw has gotten used to going forward, you heat this stuff up to where it's just really flexible. It doesn't retain the heat, so it doesn't burn their mouth either, which I really like about it. You put it in. It comes in kind of a wafer. Have them bite down into it, and MI or CO, whatever we call that these days, just all their teeth is close together in their normal biting position. And then you just take your fingers and kind of squish it up around the teeth, keeping it off the tissue. And then I usually take the air water syringe and blow on it to kind of cool it for a minute. And then you take it and you drop it in some cold water. And man, that stuff gets as hard as a rock. I mean, it's just, it literally, if you hit it against the table, it sounds like a porcelain bowl or something hitting the table. And then you try it back in and have them bite into it, make sure that it bites in. They go, yeah, sure, it feels great. Well, you're going to tell them when they get up in the morning after time that this thing's not going to normally always feel that way. You may feel like your front teeth are hitting too hard, and you want to put this thing in and bite down on it and clench your teeth. I even personally, I wear a dental appliance myself every night. I take my hand and push on my chin and really get my jaw to seat back, and I wear this thing around the morning for 5 or 10 minutes until my back teeth start feeling like they hit normally. And I think if we do that, it's really going to help a lot of the bite changes I've found in my practice. Any other thing I missed on that, Rich, you can think of?
The only other, and I like that, what you said, everything about that. If it doesn't fit right and it warped a little bit, you took it out too early, you can just throw this thing back in hot water and it turns right back into a pancake and you can refit it. So anytime you can do that. I like the chin push thing that you mentioned. And I also like doing this little tongue exercise in the morning. I have them put their tongue onto the roof of their mouth behind their maxillary teeth and then trace their palate back as far as they can with the tip of their tongue. And if y'all will try that right now, you really feel all of those muscles pulling your lower jaw back. And I agree with you, Guy, completely that most of the problems are that jaw simply creeping down out of the fossa, and we just need to reseat it in the morning. So 2, 3, 4, 5 minutes, I tell them walking around, looking for my shoes, making coffee in the morning, that type of thing. Very good. Let's go back to that previous slide just for a second if we can. And let's talk about some of the other things, the joint pain, discomfort, tooth, that type of thing. So joint usually is if both sides of the joint are hurting, you're advancing too far forward too fast. So we just slow down and back up. Okay, maybe not wear it a few nights. This is where you have the advantage, Guy, over me when you see them at 3 weeks. I get to hear about more of the problems that they have that actually go away by the time you've seen them at 3 weeks, and you're absolutely right in that.
I found that out by luck. I mean, I was on 1 week, and I really found that at 3 weeks, people are generally more happy with these appliances than they are at 1. So, again, we don't need to beat that point up. But I totally agree. If it's bilateral joint pain, it's that we've gone too far, too fast, and we need to back it up. And I might add that on occasion, I'll go ahead and add some NSAIDs for 7 to 10 days along with that. 800 milligrams of something like ibuprofen 3 times a day. I really think it'll put them over the edge. And what I tell patients, it's like you haven't been to the gym, and now you're going to the gym, and you're going to have some muscles that are a little discomfort because you're doing something different with your jaw than you're used to. And, after you start going to the gym and working out and getting used to it, you may need to take a little ibuprofen along the way. But once you get those muscles and used to it in the jaw position, it most of the time goes away. Most studies show that there's not any true internal joint derangement problems, or rather higher incidence of problems with mandibular advancement than without. So most likely it's a muscle ligament type discomfort, not the disc slipping or something like that.
Right.
Most likely.
You're right. And we do create a little bit of edema in that joint. So the NSAIDs are good with that and that type of thing. And that goes into the muscle spasms and those types of things too. I mean, you can use something like Flexeril or something like that, as a short-term type of thing if they are having some of those muscle issues. What about unilateral joint pain? What if it's only hurting on one side?
Well, that's usually, you don't find that as much with the tap appliance, but some of the appliances that are adjustable on each side, it's that one side is catching before the other, and the force of the appliances is not even. It might be that your bite was taken off to one side or another. Sometimes it requires taking a new bite and having the appliance remade if it's off too far. On some appliances that you can adjust, now with the 1 millimeter band, you might find that you could put a different size on one side than the other and maybe get that taken care of. What are your experiences with that, Rich? Usually it's the side that's hurting is the side that needs to go forward, is my experience, but not always.
I don't remember who I took a course from one time, but they said the side that's hurting is the side that's hitting.
Right.
So like with a tap, a lot of times we'll put a tap in and we don't pull the cheek back and look in the back. So if we don't seat that thing all the way and it's not all the way down, one side may be up a little bit, and what we're doing is kind of canting the jaw a little bit one way or the other. So remember, the side that's hitting is that's hurting is the side that's hitting, and that's the side we want to adjust or to build up the opposite side. Tooth pain, moving down this list, we got a lot to go through tonight, so we're trying to get through this, and we'll try to get to some of your questions that y'all are sending in too. But usually that's just a matter of adjusting the appliance. That's no different than a partial denture and it's pushing on a tooth or something like that. So that's pretty simple. Remember, salivary flow, I tell them you're going to complain the first couple of weeks that you have too much saliva, and for the next 50 weeks you're going to complain that you don't have enough. Your mouth's kind of dry.
Right, and the dry mouth's a little bit more prominent if they're mouth breathers, and if you decrease the vertical as much as possible, sometimes that can help to get lips around their appliance and not encourage mouth breathing. But I totally agree with that. What we tell patients, if a crown comes loose from our appliance, then we did you a favor, because the thing was going to come loose and you were going to swallow it or you're going to get decay underneath it. I mean, these things should not fit so tightly that they pull off a well-cemented crown. Allergies, I know that's not real common. I haven't seen a whole lot of that. I think, Rich, you've had a little more occasion to see that than I have. Can you tell me what you do for allergies?
I have, and I have had a couple of patients who were allergic to some of the materials. So it's difficult to know if that's the case or not, but there is a simple way to test for that. You can call up Keller Lab, for example, and they will send you a button of the material that they use in a tap or in an EMA. And by that, I mean it literally looks like a button, and you have the patient just tape that to the inside of their arm, between their elbow and their armpit, and if they're allergic to it, they won't be able to keep it there very long. If they're not, then it's something else, and we can move on to that. But that's the easiest way to test that.
Posterior open bite, we already talked about a little bit. Basically, that's caused from the teeth, either the whole arch of the teeth moving or the jaw down and forward. Dr. Lowe's done some studies where he shows that the whole arch can move at times, but I think the majority of the time that we get this is the jaw translated in exercise we just previously talked about, bite repositioners and alternating and such. That can help that particular side effect. Implants, you might want to relieve around those, as we talked about. Mobility and tooth movement can happen if you have a periodontally involved tooth with a poor crown to root ratio. Relieving around those teeth can help prevent that as well. The next slide, we've already gone over the AM aligner, so we're going to go on down to a little bit more about side effects.
I just want to re-emphasize that our goal is not to get the chin hitting the ceiling at night. It's just to move them forward enough to treat them. We don't have to go too far. So remember, keep that in mind, and we'll get into a little bit more of that later about how we know when we're there. But you can also alternate with CPAP. I believe that after doing this for 10 years, the patients I have who manage this disease the best alternate with CPAP. And I know, Guy, you wear a device too, and you've told me before that sometimes you just take a night off every now and then too.
Yeah, and I don't think there's anything wrong with that. We always want to say the night you take off, wear your CPAP. But truth be known, if you interviewed a bunch of sleep physicians and said, we can get them to wear their CPAP all night long, every night, 13 out of 14 nights, they would be thrilled to death to hear that was a glowing success with CPAP. So taking a night off is not good for you, but we weigh the risk and benefits. Me personally, I have worse apnea on my back. I tend to not have near as big of problems on my side. And when my teeth start feeling like they're not hitting right, my bite's starting to feel a little off, I'll throw in an old bite guard that I used to wear for years, and I'll put some pillows on my side and sleep on my side that night. And usually one night's all I need, sometimes 2 nights, and then my bite's right back to where it needs to be. And I recommend that for our patients. If the bite change is bothering them, then they have to weigh the risk of taking a night off versus their bite. And that can be very effective. I've found that to be very useful in these people who have bite changes. And using the AM aligner, as we've already mentioned, is, I think, very critical.
Expect side effects. Tell your patients to expect them. We have an informed consent. info@dentalsleepsolutions.com. We'll send you ours. If you don't have one, the American Academy of Dental Sleep Medicine has one. And remember, being alive with an open bite's better than being dead with a closed bite. So the side that's hitting is the side that's hurting. These are just little pearls there. Back up and slow down. Take a break. Just remember that you have those tools in your bag as we move forward. So when we talk,
I'd like to mention to reemphasize that top line. Being alive is better than with a poor bite is better than being dead with a great bite. That's the patient's decision too. I think that they have to understand the risk benefits and alternatives of treatment. And if they experience bite change, then they have to decide whether the bite change is worth the helping of their serious medical disorder. They need to understand what's going on, and then they make an informed decision as to whether they want to continue treatment. It's not really our decision. I think that's what I wanted to emphasize. Sorry to interrupt you there, Rich, but I want to make sure that you realize it's not our decision. Well, you should keep wearing this because if not, you're going to die. No, they might have a stroke, but they need to have that information, and then they can decide whether the side effect is worth continued treatment. It's their call, not ours.
Good point. So we've given them the device. We've adjusted it so that it fits properly. We've got them at about the most forward, comfortable position. So what's your schedule, Guy, for how fast you start adjusting? And with the tap, we're going to turn the thing. Each half turn is 1/4 of a millimeter, and with the EMA, they're going to 1 millimeter band lengths now with the number on them, the length, 15, 16, 17, 18. But what's your schedule for how you adjust it and how quickly you do?
Again, I'm kind of on the 3-week schedule. As long as they can wear it and they come in 3 weeks and they've had it in every night, we talk about their subjective findings. If they're still having subjective findings, then we'll start talking about titrating the appliance. And there's 2 camps on this. The faster we titrate them, the more quickly they see the benefits, the more likely they are to be excited about treatment, but also the more likelihood they are of having some side effects. So I think Rich and I are both more on the conservative, and I like what you put in the slide here, Rich. It's a marathon, not a sprint. I'd rather be conservative and not have these side effects. All along coaching the patient, saying, we'll get there, let's just take our time. That's kind of my protocol on it. So if they're having side effects at 3-week check, they're still not, they're not having side effects, I should say, and they're still having subjective findings, snoring, tiredness, waking up at night, what have you. We'll talk about moving their appliance forward. And normally I have the patient do this. And in a tap, we'll give them instructions. If you still feel that way in a week or so, go ahead and start turning your appliance a half turn, which is 1/4 millimeter, every 3 to 5 days, and we'll tell them to turn it a maximum of so many turns. With the EMA, we may say, okay, you have the long bands in the white color. I'll give you the next size up in the white color, as well as maybe a more rigid color, which Richard, maybe we can talk about the rigidities of them. But if you're going to a more rigid band, may make a difference. Say, try this one for a few days. If you still have symptoms, then switch to the more rigid band. Then we'll see in 2 to 3 weeks. You want to talk about there are different lengths, but the different colors.
The EMA bands come in lengths. So remember, the shorter the band length, the more we're pulling the jaw forward. But they also come in different colors, and those are associated with how firm or rigid the bands are. The white ones are the most flexible, then the yellow, then the blue, and then the clear. So like Guy said, let's say we're on a 16 millimeter band in the white. Then we might go to a 16 in the yellow for a few days, a 16 in the blue for a few days, so that's more rigid, right? Before we go to a 15, the next smaller band in the white. And we don't give the patient too many bands at any given time or too many choices. We give them a few. We tell them this is what I want you to do on this type of schedule, so that we're encouraging them to come back and follow up. And then we don't give them more than a year's supply anyway at the end of where we're treating them, so that we get them to come back for their yearly recall. So we're doing that. Next slide is defining success. We want to get the AHI below 10 and reduced by half, RDI below 15. As well as relieving the symptoms. So I don't want people to get hung up on we're just treating a number. Remember, obstructive sleep apnea is a syndrome. A syndrome is defined by a cluster of symptoms. So we're looking at that. We go to the next slide even, when to evaluate your device. We want some objective improvement and subjective improvement. So we want the patient saying, hey, I feel better. I don't have headaches when I wake up in the morning. I don't feel like I have to take that nap. And remember, we have some tools in our bag too with the Epworth Sleepiness Scale, the Thornton Snoring Scale, for evaluating objectively how sleepy they are during the day. And a lot of times this, just like the disease itself, is very insidious, and it creeps into your life so that people get more and more tired and sleepy and they don't really know it. You can also treat this disease that way, where they're getting less and less sleepy, then that becomes the new norm. So I know, Guy, you're real diligent about using this stuff all the time at your follow-up visits. And anything else you want to add to that?
No, I think having a pre-treatment idea of their symptoms is very important. And our software, we actually have places in there to evaluate and track these things. I think it's real important to understand why the patient is seeking treatment. We mentioned that in previous webinars. Track whether it's snoring, track whether it's the Epworth Sleepiness Score is high. And then once those seem to be under control or acceptable or improved enough, then we're going to do a home monitor to see if in fact we're getting enough air to the lungs to decrease apneas and hypopneas, and basically confirm that this is working. Most of the time it just confirms it's working, but not always. That's why we need a home monitor. I just don't think you can do this if you're going to do it on a regular basis. I mean, we're going to talk in a moment how you can do it temporarily or at times through doing a PSG. But if you're going to be really involved in this, go out and purchase a home monitor. They've become a lot less expensive. When Rich and I started, there was only one or two of them available. Now there's, I don't know how many, over a half dozen at least, if not near a dozen out there. And the cost has gotten down. And we believe they all work, especially if you're talking about titration. They're all going to give you the information that you need. You might look at how much it costs you each time you use it. I think that's important because if you're going to use this 3 or 4 times on occasion when you're having a difficult time with someone getting where they need to be, if it starts costing you money each time, that can get into cutting into your bottom line. And there's ones out there that are less expensive per use. But other than that, they all seem to work well. Make sure they measure the channels that we need, which are airflow, oximetry, heart rate, body position, snoring sounds, and respiratory effort, I think are critical. Other than that, you can do your own research on them. If you don't have one of these, Rich, or even if you do have one and you titrate it and the physician thinks that maybe they ought to have a PSG to confirm it's working, I think there's some good advice here on protocols for what we call the titration study. And again, that would be if you don't have a home sleep testing device, this would be a way that you can objectively get the appliance titrated at the sleep lab. You want to tell how we do that?
Yeah, and remember, you made some good points there. We're getting the patient dialed in to where we think they should be. If we have a home sleep test device, we send them home with that. Then we evaluate that with them. Let's say their RDI was 40 before. We send them home with the home sleep testing device, and the software scores it as an RDI of 25. They're still desaturating below 90 for a lot. We're not there yet. We know we need to adjust the device more. So we tell them to adjust it some more. Then we test them again. So we're using our home sleep testing device in that fashion. Now, if you don't have one, you're going to dial them into where you think they need to be. Then you're going to send them to go get a sleep study. Now, at that sleep study, the protocol that you want to make sure that the patient as well as the tech at the sleep lab understands is that, look, let them sleep for about 45 minutes. If we're not successful in treating them, wake the patient up and have them turn the tap 2 full turns, or have them use the next smaller band with the EMA, for example. Techs won't do this stuff. They're not going to say, hey, take your appliance out, let me turn it for you. They don't want to touch them, okay? But the patients already know how to do that, and they can expect that. So use that opportunity when they're in the sleep lab to do this and to do it right. Don't just tell them to go get a sleep study and they sleep the whole night and they say, hey, your device didn't work. Well, we didn't get a chance to titrate it or adjust it. That would be similar to putting CPAP on someone at 8 centimeters of water and not being able to adjust it, to titrate it. That doesn't make any sense. So we want to be able to do the same thing at the sleep lab. And this gives you an idea about how to do that.
So once we have the home sleep test and or the titration PSG and we feel we've reached maximum medical improvement, we ought to send the report to the physician. And Rich and I are in the belief, and part of the way we've structured our franchise is we write letters on our franchisees' behalf. And what we include in these final letters are, here's where the patient was subjectively. So in other words, Epworth, snoring, so forth. And then here's where they are objectively, AHI, LSAT, percent below 90. And we include that in our letter to the physicians and say, we've done everything we feel is proper for this patient. We feel they've had a good result. Here's the statistics of where they were subjectively and objectively, and we're referring them back to you for whatever further treatment you deem is necessary. We believe our job is to open up the airway as best as possible and then refer them back to the primary care or whatever physician is in charge of them. They determine any further treatment, and they also can determine whether they feel it's successful. If they don't feel that it's adequate for the patient and they want to look at other treatments, then we have no problem with that. Our job is just basically to get the airway as open as possible. But effective communication with the medical community is extremely essential in building your practices, as well as the right thing to do. Again, there's a lot of recorders out there. There's some pictures of all these here. We think they work. We've used most of them. And just do your research. We don't have time in this hour webinar to get into the details of all of them, but you can contact these companies and they can tell you the pros and cons of each of them. And the only thing we will say, if you want to use them for diagnosis, which you can do in conjunction with a board-certified sleep physician, as long as you're not a Medicare provider or they're not Medicare patients, I should say, then you want a level 3 recorder. So keep that in mind. Other than that, talk to the companies and make your own decision. But I recommend you getting one if you're going to be doing this on a regular basis. And Rich, can you tell us a little bit more of how these work and in particular just sometimes when they may not work?
Yeah, I have a story I'm a little embarrassed to tell, but I had a little old lady who we sent home with a home sleep testing device, and we couldn't get the pulse oximetry to work. And she was just distraught because she thought she was doing it wrong. And all along, it was because she had fingernail polish on. So remember that these things work by looking at the amount of oxygen that hemoglobin is holding based on different types of light that's going through that thing. So remember that you look at this guy's fingernails, man, there's no way we could use a pulse oximeter for him. So he'd have to go to a sleep lab. We'd have to measure it differently. But fingernail polish, things like that. So just make sure that you understand that there are limitations to this type of thing, and we need to keep that in mind. But remember that these are good tools in our bag. Evaluate them, like Guy said, based on per cost use, how much they cost, and how we want to utilize them. And you can certainly ask us some of those questions later. And if you want to give us a call or send us an email, we can help you out with some of that. The next slide. One of the devices, and I have 4 different ones, is the Rimmers. This is a typical type of report that they see where when it comes back, that's a 10-minute epoch. There's one on top, one on bottom. The red line that you see is the O2 saturation. The blue line is airflow. The green is heart rate, and at the bottom it's showing snoring signs. So you can see how the red goes down and up, and that's the pulse oximetry, and they're breathing, not breathing. So that's a typical slide of what a sleep apneic looks like. And these are the types of reports that you get when you evaluate these things and look at the software. And like Guy said, we like pretty much all of them, and you just have to consider some of those things. And the one thing you didn't mention, Guy, though, was the ability to upload and have these things done through the cloud, so to speak. And some of them have much more user-friendly interfaces to do that.
That's true. And when you see the screen here, this is showing the raw signals. Most all of them will generate a report that's automatically scored, and it'll say the AHI is XYZ, the LSAT's this. So you can look at the raw data here, but don't let this scare you, because with a little bit of training and a click of a few buttons, it'll score the test for you automatically and give you a decent idea of what the patient's AHI and all the other numbers that I see.
Here's a study that when we said we want the ability to actually titrate these things in the sleep lab and do this, well, here's a study by Fernando Almeida and Dr. Parker and Lowe where they actually showed this. I mean, if we just send them to the sleep lab and don't have the ability to titrate that, we have less success. So the ability to do that, and that makes perfect sense. That would be like putting CPAP on everybody at 8 centimeters of water. What's going to treat some people successfully, but not everyone. And remember, we have to turn that dial on these devices to increase our effectiveness and treat more people successfully.
So am I looking at this correctly, that by titrating the appliances, depending on what our criteria, we're getting between 17 and 30% more effectiveness
Right.
by titrating it versus just handing them appliance and I'm wishing them a good day.
Yeah, and the next couple of slides just give you guys an idea about how many studies are out there where they've been looking at actually titrating these things. Some of them even had hydraulic systems and remotely controlled things where you put something in somebody's mouth and it actually does that. So you've got to remember, go to the next slide too, Guy. Let's go one more. That just gives you guys an idea about how many of these things are out there. You've got to remember that we want the ability to adjust these things, and small adjustments can make a big difference in whether or not they work. Just like with CPAP, 8 centimeters of water doesn't work for every patient, but in any individual patient, to go from 8 to 9 to 10 completely abolishes their sleep apnea. Our devices work the same way, and we have to remember that.
Very good. So this slide here, so that I can explain it to the people watching. ODI is the oxygen desaturation. So 26 times an hour as we move it forward at the top line, 17, 14, and down to 10. So that's what the ODI, in case someone doesn't know. And then the time below 90% is the next line, and then the average oxygen saturation. And let's remember the practice parameters. I think we've mentioned in our previous webinars, this is kind of the day the earth shook for dental sleep medicine when the physicians finally said anybody has mild to moderate apnea could be given a choice between a dental appliance and a CPAP, and anybody who has severe apnea and can't wear a CPAP should consider a dental appliance.
And I like the way you put that, Guy, the way the earth shook, for us dentists. We keep waiting for it to shake a little bit more. We're fighting this medical model that just is PSG and CPAP, and we're making inroads, and we need more dentists out there like you guys making these devices and doing your homework and learning about it. But, don't forget, we want to use our physicians. We want to involve the primary care physicians and the sleep docs, and we want you to build those relationships with those people. And, the practice parameters say exactly that, as well as we need to continue to follow up with them and do those types of things. So where can you learn more about this? We've mentioned this before, the book by Hokema when he did his thesis. There's the Principles and Practice of Sleep Medicine, the textbook. I'm also going to point you to Dr. Thornton, his airway management site, and through that site you can see TAPS, what they call their white paper, and that's just a narrative that's very well documented about the disease itself as a public health problem and where dentists fit into that. I don't think we mentioned that particular thing before about where you can learn more, but I would steer you towards that. If you can't find it on that, again, info at Dental Sleep Solutions, and I'll send you a copy of that.
Yeah, it is a very good paper. I read it for the first time a couple of years ago and enjoyed it. All right, again, with the house cleaning, if you want to get credit, make sure that you answer the 10-question quiz in the email that we will send you. Click the link and email it with the required info, and you need your AGD number, or put NA on it where it asks for the AGD number if you do not have one. Finally, we'd like to talk about Keller and thank them again for sponsoring this. We really enjoy working with them, and we want to point out that they're a good resource. If you have questions, they can certainly answer. They've made thousands and thousands of, if not hundreds of thousands of dental sleep appliances, and their crew over there are very knowledgeable. And again, we can talk about Dental Sleep Solutions for a moment. If this seems like it's interesting to you and you'd like someone just to push you down this road and take care of everything from start to finish for you, we're the guys for you. Rich and I can help you do that. We have the only turnkey solution out there from start to finish that's run by dentists who have done this themselves. We'd be happy to talk to you more about that. You can contact us at info@dentalsleepsolutions.com. And don't forget our next one coming up. We're going to talk about getting paid and marketing for this, and we look forward to seeing you there. Do we have any time for any questions? We've answered a few here, but we're typing in between you talking, Rich, and so forth. We've answered some. I don't know what our time is.
Yeah, we're getting late. So, again, thank everybody for tuning in tonight. We appreciate you guys taking some time out of your busy schedules to listen to us. Last one, November 9th. Also, Keller's website, you're going to learn some more about the in-person courses that we're going to be doing next year. So thanks again, everybody, for tuning in. We look forward to talking with you again on November 9th. Bye.
Good night.